talk on pediatric skull tumors and the most common ones that we see in the pediatric population. I will probably not get into the depth that we were able to get into with some of the individual tumor types. And the other important thing about this is a lot of these are not isolated to a neurosurgical disease process. So many of these are inherent team-based care pathologies. So what I wanted to do is review some of the common skull lesions and tumors that we have, what the workup is, and what the different management and the efficacy. As I explain this to all of my pediatricians when I'm going out and giving lectures to them, this is what I call the bump on the head. This can be anything on this list, anything from a dermoid cyst, lipomas, just bony spurs. They're feeling the occipital protuberance and don't know what that means. Atretic encephalocele, fibrous dysplasia, the cephalhematomas or sebaceous cyst, and Langerhans cell. So I'm going to be focusing on these three because these are the ones that we're most likely to get involved in over time. So when you're thinking about these patients and what do you want to know about this, well, when did you first notice it? You know, are they presenting in infancy? Are they presenting later in life? When did you first notice it? And probably the most important thing, if you've ever seen a toddler with any bump on their head, was there any history of trauma? Did this sort of appear overnight? Was this something where they went and smacked their head and nobody happened to see them? It's getting better, getting worse. You want to know if there's been any change. Is there any pain that's associated with that area? In particular, things that you want to be very much more concerned about is if there's any skin changes. Is there redness? Are there focal hairy patches around this area? Do you notice any rashes or anything on the skin? Is there any drainage from the lesion? And then probably the most important thing is assessing what it does with Valsalva. Does it change when they cry, when they poop, when they sneeze or cough? Is there any change in the way that it feels? So on physical exam, you want to understand what the size of it is, whether or not it's a mobile mass or a non-mobile mass, if there's any tenderness. You want to pay particular attention to the skin surrounding the lesion. And then usually what I'll end up doing in the younger babies, I'll just start tickling their stomach until they either start giggling or crying and seeing what the mass does during a Valsalva maneuver. In older kids, I'll ask them to cough or strain like they're going to poop or try and fart if you get some of the younger kids that will find that entertaining. So the first is dermoid cysts. These are inclusion cysts. They're formed when ectoderm tissue remains attached to the dura as the membranous plates form. These are typically benign lesions. They have stratified squamous epithelium surrounding them. They're most commonly near the suture lines. They can appear at the anterior and posterior fontanelle, but they can really occur anywhere throughout the scalp. Most commonly, we do see them periorbital, postauricular, and then the nasofrontotemporal ones. The nasal ones you have to be particularly concerned about, and frontotemporal. Most often, these present in infancy. Mom will be feeling the kid's head and will notice, hey, there's this bump that doesn't seem to be going away. They occur anywhere from 15 to 22% of kids, and the intracranial extension is actually not very low, 1 to 2.5%. Although it seems low, it does mean that the threshold for getting imaging, especially in the midline lesions, as those are much more likely to extend intracranially, is much more indicated. They can extend intradurally, again, more commonly in the midline. And the last thing that you want to do is go into this thinking that you're just going to pop out a little cyst on the scalp and have it attached to the sinus at the midline. So they're classically non-tender. They're usually well circumscribed. They can be small. They're slowly growing. They're typically covered by skin. The other thing that you notice is this little nasal pit. It can be anywhere from right here at the nasion to anywhere along the nasal tract, and that's the opening of the dermal sinus tract. You can see areas where they have a little bit of surrounding hypertrophic hair, which can also be indicative in atretic encephaloceles. So again, things that would prompt imaging, such as any pulsations with Valsalva where you think that there's some intracranial extension, can help to differentiate that. Over time, as they grow, they can erode through the skull. Oftentimes, they have a little pit in the skull when you take them out. And historically, there's a very low likelihood of any malignant transformation. There's only rare cases reported. The problem is that because they're inclusion cysts, as I explained to all the families, they're going to continue to produce skin and hair and all of the secretions that will just cause it to continue to grow. This is what they look like histologically. You kind of see that squamous epithelium. And then as far as evaluation, an MRI would be probably the best. You can get a CT, but in order to spare the radiation, CT is really good to get an understanding of whether or not there's bony involvement or bony erosion. But in the diffusion-weighted imaging, you will see a little bit of diffusion restriction. It demonstrates that fat content. This was a case of a patient. She had a little nasal pit right on the tip of her nose, and she had this kind of waxing and waning bump that would occur right here. And you can see she ended up having this tract going from her nose all the way up intracranially. This was actually a case that I did jointly with the plastic surgeon, because I don't know about you, but I don't want responsibility of what a child's nose looks like in about 10 years. So we were able to do that together. He removed the central portion, and I was able to track this backward, attached right at the surface of the sagittal sinus. So for these, again, this is helpful most commonly when these areas are within the midline, generally between the pupils, anywhere along the midline, just to make sure that it doesn't extend intracranially, there's no sinus involvement, or this isn't an encephalocele or some other pathology. Whether or not a biopsy is indicated, actually, without any prior workup, the biopsy, the risk of that is that it's actually going to seed the contents. If you seed the contents somewhere, then this can recur just on the basis of that living tissue having seeded another area. Treatment for these, complete surgical resection can be curative. This is just an inclusion cyst. It's a benign entity. This is kind of the classic look right there, a little bit about a centimeter. It looks like a pea. If you cut that open, it'll just have that yellow sebaceous content that will spill everywhere. Any residual does pose a risk of recurrence, and anytime that you have intracranial extension, you will want to monitor that because any residual of the epithelium can cause recurrence there. And depending on the extent of this, you may want to consider options to reconstruct the skull if there's a large bony defect. So the next that I wanted to talk about, and I think I'm making good time, about a third, Langerhans cell histiocytosis. This is another one of the more common pediatric pathologies. This is the abnormal proliferation of Langerhans cells. This has gone through a whole bunch of different naming. The other histiocytosis X, and several of those various people that decided that 3 of them were going to get together and have an entity named after them. Just kept transitioning names. But it is an abnormal proliferation of Langerhans cells. It's one of the hematopoietic disorders. It's most common in children under 18, with an incidence of 4 to 8 per million children. Interestingly, there's head and neck involvement is very common. There's some of the largest series out there. There's 2 series that have about 40 and 80 patients in each of them. They note up to 73% of patients have head and neck involvement. And about 15% of patients will actually have CNS involvement. This is the pituitary stalk where they'll present with the endocrine abnormalities. The most important thing to know going into this when you start thinking about treatment is this a single organ problem or is this a multi-system disease? Younger patients tend to have poor prognoses. They more commonly present with the multi-system disease. So this can present in a number of ways. This can be they notice a bump on their head. They can have an incidental finding on imaging. Some kids will have recurrent ear infections. They'll have cervical lymphadenopathy because this can spread through the lymph nodes. They can have hearing loss from involvement of the temporal bone. Sometimes the kids will manifest with skin disorders and they just have a rash that's not improving with any other normal rash treatments. And then for those that have the CNS disorders, because this can affect the pituitary stalk, they can have diabetes insipidus or other endocrine dysfunctions, with growth hormone dysfunction being the most common. So when you do get imaging, this is kind of the classic appearance of Langerhans cells, multiple lytic lesions in the skull. You can see all of these if that's projecting well. If you do get an MRI, there is an enhancing component. This can actually track intracranially, extradurally, and will cause lysis through the skull. Now the workup for this, a skeletal survey. We don't think a whole lot about just doing plain film x-rays anymore now that we have all this MRI and SPECT and PET and everything fancy that we want to do. But truth be told, for Langerhans cell histiocytosis, that one of the best ways to stage this and understand the extent of the involvement is a skeletal survey and a chest x-ray looking for lung involvement. You want to get standard labs with liver function tests. Involvement in the liver does portend that poorer prognosis. A urinalysis to assess the specific gravity, that's to look for any subtle CNS involvement. The abdominal ultrasound will give you an idea of any liver or spleen involvement. And then if there are endocrine abnormalities present, you'd want to consider an MRI to actually take a look at the pituitary stalk. There are a couple different classification schemes that have been proposed. Most commonly, you think of this as either a single system or multi-system. With the single system Langerhans cell, there's only one organ system involved. That can be bone, skin, just the lymph nodes, lungs, the hypothalamic pituitary, or other glands. Any time that there's two or more organ systems involved, that is multi-system. The risk organs, as we talked about, some of the ones that lead towards a higher complication rate. The other proposed group, and this is the Langerhans Cell Society, is the LCH3 classification. This talks about the multi-system extension with and without risk organ involvements, as well as multiple bone localizations, or if there's a solitary bone lesion. That group 3D, that solitary bone lesion, is probably the best prognosis of all of them. So as far as the treatment, our role in this is fairly limited. It's usually us getting tissue for the diagnosis. So a tissue diagnosis, most of these skull lesions, if they're very superficial, will provide a pretty good safe biopsy site. With single site involvement, the treatment may just be to observe, or if it's a single solitary lesion that's excisable, say on the parietal, you can take it out, reconstruct the skull with the split thickness bone graft, and that may just be monitored. Other than that, for patients with either more extensive involvement or multiple system involvement, chemotherapy is the mainstay. Vinblastine, they will give prednisone as well for treatment. Topical corticosteroids are the treatment of choice if it's isolated to the skin. And then for the high-risk patients, those are the ones that are getting enrolled in some of the other studies by the Langerhans cell group. They're adding methotrexate or the 6-mercaptopurine. But there's little indication for radiotherapy. This is largely a chemotherapy-related disease. So the indications for systemic treatment, if you have CNS grist lesions, that's CNS involvement of the pituitary stalk, single system with multifocal bone lesions. If you have special site lesions, and then the special site being the spleen and the special site are the potential risks, so involvement of the vertebrae where you're risking spinal cord compression, involvement of the skull base with brainstem compression with growth of those lesions, then those would be considered also very high risk to perform just local treatment. The involvement of risk organs, the ears, eyes, oral cavity, and other craniofacial areas are considered the risk. So the prognosis, the high risk, again, liver, spleen, and bone marrow puts these kids in a lower success rate group. Also very young children under 2. They have about an 80% survival rate, so all things considered, it is still, for one of the pediatric cancers, it is still a high survival rate. But compared to those that have the low risk, either skin alone, bone, or if they have multiple organ involvement, but it's sparing the liver, spleen, and bone marrow, they have a 99% survival rate with treatment alone. So these are kids that can get very successfully treated. Our role is usually just getting a small piece of tissue and understanding that if you do see a kid that presents initially to you where this is the differential, think more along the lines of conservative and start with a biopsy before thinking about a very aggressive resection. And lastly, we'll talk about fibrous dysplasia. So we're going kind of from our biggest role to our least role operatively, with the exception of some areas of consideration. Fibrous dysplasia, this is a bony dysplasia. The bone itself is replaced by fibrous tissue. It's interwoven with the bone itself. There's three main types. There's monostotic, where it only affects one area of one bone, polyostotic, where there's multiple areas of involvement, and then syndromic, associated with the McCune-Albright syndrome. This is a polyostotic fibrous dysplasia along with endocrine dysfunction and cafe-au-lait spots. So this is thought to be associated with the mutation of the GNAS1 gene. This is actually affecting the skeletal progenitor cells. It creates dysfunctional osteoblasts. Head involvement is actually common in monostotic patients. It can be up to a quarter of them. But if in polyostotic patients, over 50% of them will actually have head involvement. Oftentimes this is asymptomatic, but it's largely a cosmetic issue. They do end up with palpable bony growth. They can end up with compression, depending on where the bone is growing. They can have compression of their optic nerve, their auditory canal. They can have nasal passage obstruction from fibrous dysplasia in their midface. And again, like I mentioned, this is awfully a cosmetic consideration for treatment. So here are kind of some of the more straightforward ones. This was a patient of mine. She presented with this sort of bump on her head that was slowly growing. I ended up going in and just shaving off a small piece of that for a biopsy because, again, I have an area of a slightly lytic bone lesion in a young patient. One of the things that was on my mind was the potential for Langerhans cell. So rather than opting for a big aggressive resection, I got a small biopsy. It came back as fibrous dysplasia. I had no intent of actually doing anything except she started complaining that it was always bothering her. We worked her up and she had no other sites. So in a monostotic fibrous dysplasia where you can achieve complete resection, assuming that there's not other sites that are indolent and too small to detect, she can essentially be cured of that area. So she underwent a resection and a split thickness bone graft, and she's been doing well with no other concerns there. This is a patient that I am getting ready to deal with. She's having slow growth. It's a teenage patient with progressive deformity, protrusion of that eyebrow. The entirety of the involvement is actually her frontal bone and her top of the brow. So this is somewhat that the plastic surgeon and I are going to be doing a reconstruction. Again, I know my place. I would like to safely get off the skull and have him make sure that her facial asymmetry is improved. And then you have kind of the more complicated cases. What do you do with this? What are you concerned about? What about this over here, where you've got involvement within the nasopharynx, you have involvement over the orbit? So there's not really any successful medical treatment. They've tried some of the bony medications, pimendronate, not really super effective. So you want to think about your different surgical considerations. Are you doing something prophylactically? Are you doing something because they became symptomatic when you have significant compression of the optic canal? They've been competing studies. Some people will prophylactically decompress the optic canal and get about a third of patients that will have vision loss because of the compression of the optic nerve during the surgery. They have patients that wait until they have studies where they wait until the patients already have vision loss, and then some of them will never be able to regain it back. So it's still a matter of up in the air as far as what the best option for treatment is. Then do you try and form a complete resection versus a partial resection? On the page that I showed you before, both of these we can probably achieve a complete resection and not risk it coming back. Something like this, a little less so. Same with over here. Again, this is a general idea of, do you want to be more conservative if you know that you're not going to be able to get everything out and have any sort of curative process? And then what's the timing of the surgery, the impact of the surgical resection on the remaining skull growth? The younger that you present, if the midface is still developing under the age of 8 years, then doing too much in the midface can actually affect the growth plates and the growth of the skull. Because this is already largely a cosmetic disease, impacting the midface growth even further can complicate things down the line. There is a potential for cure in monostotic fibrous dysplasia if you're able to achieve a gross total resection, but again, there's no guarantee that you just aren't missing smaller lesions that haven't progressed in growth. When you do achieve surgical resection, or when you do pursue that, the texture of this bone is a lot softer. It can be drilled out. It can be scraped out by curette. You can usually clearly delineate the margin of that fibrous area of involvement. You want to consider reconstruction. A lot of times this is where having a great team with a plastic surgeon or an ENT can be helpful. You want to make sure that you have a bony edge, but sometimes if you have a lot of expansion and something like this here, if you were to remove the orbital roof, the bony expansion kind of circumferentially around it can make it a little more difficult for reconstruction, so you want to be able to try and plan out that ahead of time. You can do split thickness bone graft to reconstruct defects in the skull vault pie, and you may have to do some recontouring of the edges, just as in any sort of craniofacial plastic case when you want to think about how everything is going to heal over time. And then depending upon the extent of facial involvement, you may require multiple surgical approaches. Something like this would likely need to be addressed both from above as well as through the nose in order to relieve the symptomatic obstruction of the nasal passage. So I didn't do too bad on time here. So in conclusion, just in thinking about the way that you would approach a bump on the head, they're most often very commonly benign entities, but it doesn't necessarily predict a benign clinical course. Dermoid cysts, probably the take-home point for that. Anything near the midline should be evaluated for any intracranial extension. If you're able to achieve gross total resection, this is curative. For Langerhans cell histiocytosis, the mainstay is chemotherapy. But we are needed for biopsy for diagnosis. Make sure that it's always in your differential for a child with the skull lesion. And then fibrous dysplasia, probably the most difficult of these to treat. It's a progressive, very difficult disease process to manage, where it's largely cosmetic, but there are also functional considerations.
Questions? So I guess, those monostatic fibrous dysplasias that are not in the skull base, that are incidentally found, what is your approach?
So I kicked the can down the road as long as I could on that, girl. For me, I'm fairly conservative of those types of things. I'd rather put myself out of a job than just go aggressively operating on any child. It really took her coming to my office 3 or 4 times complaining of pain that was localized to that site. And I think once she was aware of it, it was as much psychological as it was physical for her.
Okay.
So I'm much less aggressive.
Jim, I mean, what's your approach on this? Sorry, put you on the spot, but.
Actually, I'll make 2 comments. Going back to the optic nerve, very aggressive early on in my career, and then I learned from the ophthalmologist that they were following these patients for long periods of time with horrible-looking CAT scans and MRIs, and I stopped operating on them about 15 years ago, and I was yet to have my first patient totally lose vision. They get visual deterioration, and one of the things I also found out is that when you take the bone on a fibrous dysplasia off the optic nerve, you're taking away its vascularity. Because a lot of the vascularity is coming from the bone due to the compression, so you're actually devascularizing. In fibrous dysplasia in general, I stay away from them as long as possible. It's a lifetime annuity. There are 2 diseases that I deal with as a pediatric neurosurgeon, is neurofibroma and fibrous dysplasia. These kids never go away, and like with neurofibroma, again, I have to be pushed into the corner. Because once you start operating on them, it's a very difficult tissue to work with. Even with the best plastic craniofacial teams, they're still contouring. So I'm very conservative when it comes to this particular group of patients.
I wanted to ask you about if you have any case that have dural involvement with dysplasia. We have a case like 1.5 years ago, and MRI shows that there is an area where the dysplasia actually have some dural component. So even when we can remove it, we don't know how is the follow-up of this patient.
So I haven't seen a case. I'm very similar. I will veer away from these as long as possible. I think the only 2 that I've been forced into with my arm twisted are the 2 that I showed being my cases. The other ones I've pulled having not been very aggressive in treating the fibrous dysplasia. I think during 7 years of residency, we only actually opted for 1, and it was because of progressive vision loss, and it was purely to decompress the optic nerve.
Yeah. Do you ever not operate on dermoids? The reason I ask is during my training, I had one of my mentors said, "Oh, they just kind of burn out over time." I generally take them out, but I have seen a couple where parents refused and they grew into the head. Do you ever not take them out, and do you know what the natural history is without taking them out?
So the natural history typically is the concern that they will further erode the skull. Usually those are the ones that are a little less mobile, fixed on exam. I've had a couple that I've not taken out because the parents were a little skittish. One of them went away, and they also refused an MRI, so I couldn't. It was a post-auricular. I couldn't guarantee that it wasn't a lymph node. I was trying to get them to just get an MRI, and they refused, and then came back, and it was gone. So I suspect it was probably a lymph node. I'm probably more conservative, still being pretty early in my career. I will still image all of them because I want some confirmation that I'm not causing a child to have a surgery to take a lymph node out.
Interesting question, because we have a population that comes up from the Caribbean. We call it from the DR to the ER to the OR. And we've had actually probably at least twice a year kids that come up that have been untreated. And it is amazing what these things can do, particularly the ones over the fontanelle. Some of them look like golf balls left alone. Mm-hmm. So I haven't actually seen one disappear, and if I did, it was probably a lymph node. But we're actually probably more aggressive with them.
Yeah.
And I think I would say the same, because I mean, I've followed some where the parents have refused surgery, and of the 3 families that refused it, they all grew within 3 to 4 years' time. So, I mean, I think you can wait and watch them, but in my opinion, I don't think they go away. If they do go away, I think it might be something else rather than dermoid, or it's going intracranial rather than extracranial, and you don't know it without imaging. The other question is for the LCH that you take out, how do you reconstruct the skull? We're gonna, I mean, Dr. Goodrich is gonna speak about it tomorrow, but just for the LCH, because I'm always, I've got the dilemma of how do you reconstruct for those isolated cases?
So for the single isolated cases, if I'm really pushed into doing more than just a biopsy, we've clearly identified that the kids are single site of involvement. If they're old enough for me to get a split thickness bone graft, I'll do that. The younger kid, the only younger kid that I've done, I've used just like a DBX bone putty, scrape the edges of the bone and put a resorbable plate, and I'm crossing my fingers and hoping that bone forms across.
Little trick of the trade. Actually, most of the time I just take out the eosinophilic granuloma. If the kid's got good dura and good periosteum, it refills back in. And the kids that don't, you can make a craniotomy and you offset it. So the 50% is on normal dura. You take it off and you just flip it 180 degrees so the hole is over osteogenic material and the defect is covered by the bone that you put on it. I do the same thing with the cephaloceles, particularly in the occipital region.
That's a really good trick. Any other questions? Thank you, Crystal.
Thanks.